Hi, my name is Candy Steele, and I'm going to present to you my Bridging Healthcare Gaps in Rural Communities, a comprehensive interventional strategy. The theoretical framework chosen, I chose the REAIM, that is to reach effectiveness, adoption, implementation, and maintenance. The justification for my use of this specific study technique was REAIM, RE-AIM is a widely used rural healthcare research tool that emphasizes on real-world applicability and sustainability. It addresses the unique challenges of rural settings, such as geographical dispersion and limited access to care. Particularly, it is useful for evaluating both individual and organizational level outcomes in community intervention. Evidence supporting the intervention. My proposed intervention was a community healthcare worker-led chronic disease self-management program for rural adults with hypertension, diabetes, and other chronic illnesses. My supporting research is supported by the study provided by Schaefer, Paulin, and House. Schaefer discusses the community-based skill-building intervention to enhance healthcare literacy among older rural Americans. Key findings to their study showed improved self-care management and healthcare literacy. Face-to-face delivery were preferred due to limited broadband access. In the study provided by Paulin in 2024, COPD and rural health, environmental exposure and morbidity was a summary of their specific study. In this, the findings were identifiable, modifiable environmental and behavioral risk factors, and they emphasized specifically on community-tailored education. In et al., in 2024, they discussed pediatric low value in care in hospitals with other chronic illnesses. This highlights disparities not only among pediatric patients but adult as well, and it underscored the need for local engagement and tailored interventions. My implementation plan is aligned with the JHNEBP aligned patient identification and screening strategies. My target population were adults greater than 45 in rural health America with diagnosis specific to hypertension, diabetes, and COPD. Screening tools was documentation of emergency room visits for COPD exacerbation and or asthma, blood pressure and A1C screenings at local clinics and community events, and health literacy assessment using the new technology such as apps, home logs for some that don't have access to internet for effectiveness. Interventional implementation. We used a delivery model where we used community health care workers that were trained in chronic disease education, motivational interviewing, and cultural compliance. The plans were to set up weekly sessions, whether it's weekly, bi-weekly, or monthly, for every 6 to 8 weeks at community centers in churches, just to educate and reinforce and continue to plan the future for this specific intervention. We planned home visits for high-risk individuals and those who were in poor health and unable to travel. The curriculum topics we discussed was medical adherence, nutritional and physical activity, stress management, and navigational healthcare systems. Our outcomes we plan to use as the Johns Hopkins evidence-based practice model for evaluation of care. In the REAIM we used REACH. The metric system was a percent of eligible patient enrollment. The tool we used for success was enrollment logs. Again, we used effectiveness, change in the BPA1C and a decrease in the COPD exacerbation visits to the emergency room. How was that provided? With clinical records provided. The adoption of the number of community health workers trained and retained at a long-term level were kept in training logs for evaluation. The implementation we used were measured by session attendance and fidelity. This was kept by community health worker checklist. Maintenance was provided, follow-up for patients at 6 months and 12-month intervals, patient surveys for clinical data. Timeline for implementation of our project fell in a phase. The planning phase is where we included stakeholder engagement, community health worker recruitment, and curriculum adaptation. This will take months 1 through 2 as the duration. Training phase will include the health workers training and pilot testing, and that is a 3-month increment. The implementation phase is program delivery, and that plan is for 6 to 8 weeks, lasting 4 to 5 months. Evaluation phase is our collection of data and analysis for a 6 to 7 month time frame. Dissemination phase, we share the findings with the community and other pacemakers. This will be completed by month 8. The references we used were Brady 2024, Schaefer 2020, Paulin 2024, House 2024, and John Hopkins Medicine Evidence-Based Practice Models for 2025. The theoretical framework we use, according to the John Hopkins model, aligned with our evidence goals and provided structured approach to translating the evidence into practice. Stakeholders engagement, evidence appraisal, and outcome measurements for rural healthcare interventions provided to be successful in these findings. And with the evidence that we had provided with our references used, the dissemination plan for rural healthcare intervention, we were able to focus our objectives to raise awareness of the CHW-led chronic disease management program. We were able to promote adoption of the intervention by the rural health communities and stakeholders. Our influence policy and funding decision to sustain and support further sustainability. We also used community flyers and brochures, infographics and data such as social media and news, policy briefs from local governments and health departments, webinar and podcasts by partner organization, and conference presentations done annually. Local media engagement such as radio interviews and newspaper opportunities will be used as needed. Toolkits for replication shared with other healthcare community volunteers. We will consider adaptation and look for feedback from those individuals. And at this time, I'd like to present to you my poster that is including all this information for integration into a comprehensive strategy for bridging healthcare gaps in rural communities. Thank you for your time. Have a good day.